This podcast is produced by the Center for Deployment Psychology at the Uniformed Services University of the Health Sciences. The views expressed are those of the speakers and do not necessarily reflect the opinions of the Uniformed Services University, the Department of Defense, or the U.S. government. In addition, references to any specific companies, products, processes, or services does not necessarily constitute or imply endorsement by the Uniformed Services University, the Department of Defense, or the U.S. government. Welcome to CDP's podcast, Practical for Your Practice,
where we give you actionable intel to support what you do.
One colleague to another. Hi there, I am Jenna Ermold, and I'm joined by Andy Santinello, who you've heard many times before. And today on Practical for Your Practice, we are really excited to have one of the Center for Deployment Psychology's experts in chronic pain, Dr. Sharon Birman, join us. So welcome to Practical for Your Practice, Sharon. So good to have you.
Thank you for having me, Jenna. I appreciate it.
So Sharon, I got to be honest with you. We just really wanted to have you on the podcast because we like talking to you. And so we thought we'd get you on here to talk about some of the things you also do for the center. So that's, that was our ulterior motive today.
Yeah, exactly. How could we possibly have a conversation with Sharon?
Well, I'm ready for that conversation.
Good. Well, in all seriousness, one thing that we were talking about that we thought would make a good discussion for in this forum is the notion that a lot of times for many of us, we may be doing an evidence-based psychotherapy for depression or, be doing cognitive behavioral therapy for insomnia or one of the treatment protocols for PTSD. And this guest kind of comes into the clinical room called chronic pain. So our client is struggling with, PTSD, but also really suffering from chronic pain. And it can be something that some providers have gotten a lot of training in chronic pain, some not at all, but it can create a lot of choice points and potential areas of struggles for providers. So we wanted to have a conversation about that today. Like, what do you do if you're mid EBP and either chronic pain really starts to present more or seems to be taking center stage? How do you manage that? And maybe talk about some resources. So that was kind of setting the stage for today.
I think we have certainly come a long way from the biomedical model of pain, right? So we know now that pain is a lot more than just the simple signal from soft tissue to the peripheral nervous system to the central nervous system. We know that the pain experience in and of itself is related to physical components, but also to psychological and psychosocial components. And because the pain perception is actually related to these factors, understanding the psychological and psychosocial factors of pain can really, I think, impact the treatment. We know that there's a high rate of comorbidity with a variety of diagnoses, things like depression, anxiety, PTSD, substance use disorders, insomnia, all of those things that you were just mentioning, Jenna. So really, I think getting into understanding where is some of that overlap. So if you're working with somebody that's coming in for depression, coming in for anxiety, for PTSD, and you're really working on appraisal and cognitions, then that's what you want to start looking at with pain as well, particularly those catastrophizing cognitions. There's a lot of information, evidence in the literature that really kind of talks about the negative role in pain outcomes because of some of those catastrophizing cognitions. So really starting to look at some of those things, starting to look at possible active coping, right, to prevent negative outcomes, doing things like distraction techniques, as much activity as you can safely possibly do, relaxation techniques. All of those things, I think, can really be integrated very nicely into the EBPs that folks are already engaging, whatever it is they're doing.
Because we're already talking a lot about cognitions and we're already talking a lot about behaviors. And so I think that's whether we want it to show up or not, those pain-related cognitions definitely, they're always strong and extreme. They, similar to some of the other things like, when we hear sleep treatments, I can't stand this anymore. I'm never going to function if I don't get sleep. Similarly, because pain is so disruptive and hard to tolerate for so many people, those tend to be incredibly strong thoughts too. And not to sort of call on Andy as our mindfulness ACT guru, but I imagine you have some thoughts about that and in the ACT world as well.
I do, in fact. But my first kind of thought was more, just the whole clinical context. And Sharon, you were talking about some of the strategies and techniques that could be used, to deal with pain when it shows up. And Jenna, you kind of introduced this as in the course of EBP, pain might just be an unexpected, uninvited guest. And one of the things I was thinking about as you were talking, Sharon, is I was thinking actually about a client that I worked with a couple years ago when I was still in VA and we were doing CPT together. And chronic pain was not something that he presented with initially. And about 2 or 3 sessions in, I noticed that whenever he sat down, he would sort of wince and go, and grab his lower back. And he had lots and lots of catastrophic extreme thinking. So one of the things I was starting to think about is how much just the presence of chronic pain, especially when it's not acknowledged and talked about, may actually sort of fuel unhelpful thoughts. And so, even just addressing it, calling it out, saying like, is your back hurting? Is this a chronic issue for you? How often does this come up? Do you notice when your thinking is more extreme, you're also in a lot of pain? So, maybe making those connections could be an important part of this too.
Yeah, absolutely, Andy. And with depression, I think it's particularly prominent. There was one study that looked at VA patients and found that 54% of patients with a diagnosis of depression coming in for treatment of depression had a diagnosis of chronic pain as
Hmm.
well, right? And so we see a great deal of overlap. And I think absolutely they're impacting one another, right? It's kind of like the chicken or the egg. We see this a lot with insomnia patients too. Are they not sleeping well because of the pain, or is their pain exacerbated because they're not sleeping well? Same idea here, right? Are they feeling more depressed because they have this chronic, debilitating, relentless pain that is an awful lived experience? Or is their pain worse because they're so depressed that they're going into this cycle of inactivity where they're not actually getting up and activating? And now what we're seeing is a great deal of muscle atrophy, which is actually making the pain worse. I don't know that we necessarily know the answer, but I think it comes back to exactly what you're saying, Andy, which is these cognitions are both playing a role. And either way, these thoughts of, I can't take it anymore, I can't deal with this anymore, it's never going to get better, I think are both reciprocally impacting the pain experience and the depression experience. And so, kind of starting to delve into those things, whether it's starting to talk about breaking the cycle of depression using behavioral activation and also noticing the pain. So, as I'm talking about behavioral activation, how do I start to incorporate discussions about pacing? Really teaching them about the cycle of chronic pain, where we move from overactivity, right? Folks with chronic pain tend to have this, oh, I'm having a really good pain day, I feel really good, so today I'm going to do everything. I'm going to clean the garage, I'm going to organize my closets, I'm going to do everything. And then all of a sudden they start to feel this extreme pain where they feel totally debilitated. So they're laid up on the couch for 2 days. And it's almost the equivalence of yo-yo dieting, right? We're going from one extreme to the other. So as we're talking about behavioral activation, we're providing them with psychoeducation about, let's get you up and activated. Let's break the cycle of inactivity. Let's really talk about those environmental sources and how we start to incorporate pleasuring and mastery activities. Well, how do we also talk to them about pacing? And also, you have this chronic pain condition. So let's also teach you about that and make sure that as you're getting activated, you're also taking these periods of rest so that you're not engaging in that overactivity.
And along with that pacing and figuring out how to deal with the pain consistently, I think one of the things that you mentioned in terms of the behavioral activation that could be important to keep in mind, which might actually help with that, is linking maybe that way of approaching pain to something that's really important to the client. So are they getting really active just because they don't feel a lot of pain that day? Or is there activity in the service of, spending more time taking care of their health? Or are they more active because, they're spending time playing with their kids or grandkids or doing work around the house? Or so linking it to something that's consistently important to them and really creating sort of a new life habit in the service that may help to uncouple the activity or an activity level with presence or absence of pain.
I absolutely agree. And I think we could do that on both ends, right? Am I identifying that they're engaging in overactivity because it's so valuable for them to spend time with their grandkids? Or are they engaged in so much underactivity that I have to kind of work with them to identify their values and start to figure out how they engage in activity because those things are important to them? And how do we start to engage in value based behavior?
And so that part of it, I think, is really interesting to talk about too, because I think that when it becomes about what do I do to manage my pain, one of the things that might increase pain is spending more time doing something important to you, and that's where that inactivity comes in. And I'm just kind of curious, and I know I'm putting you on the spot here. If you
That's
were
what
dealing
this
with
podcast is all about,
I
Andy.
should just
Called the hot seat.
putting you on the spot. That's a tough situation because obviously someone who's dealing with chronic pain doesn't want to feel pain. Pain doesn't feel good. And avoiding feeling that pain may be really getting in the way of their functioning in some really important life affirming ways. And you talked about all those connections between chronic pain and depression and also anxiety and other things. The more someone is not doing the things that are giving them that sense of pleasure or mastery, the more that they're going to feel depressed, the more the pain is going to impact them. Do you have any thoughts about just maybe a first step in beginning to break that cycle and maybe helping someone to paradoxically move towards an activity that may bring about the experience of pain?
Yeah, I think coming back to pacing, that can be a really effective way. So the idea that I have to do something for a full hour and moving away from some of those ideas that I have to finish a task within an hour, but rather I could break it down into 15-minute tasks and still get it done. If I do it for a full hour, I may be again laid up on the couch for a couple of days or even a week. And then it's so aversive that it becomes kind of in that cycle of depression, right? Those like aversive experiences are things that we start to avoid. So then I don't want to do it again for a month, but rather if I do it for 15 minutes, take a 15-minute break to engage in another task, do it for another 15 minutes. Now I might be able to complete this task. Another thing I think is really important to talk to patients about is how do we modify the things that they love to do? Just because you can't do exactly what you love doing in exactly the same way that you want to do it doesn't mean you can't still engage in the things that are valuable to you. So if you used to love to play football and you can't play football anymore, can you coach a football team? If you used to love working on cars and you can't work on cars the same way you used to, can you teach your son or your nephew or somebody in your family to fix cars and engage with them as they're doing it and find some value or satisfaction in that? I once worked with a patient at the VA, and here in Los Angeles, we have a lot of folks that really like to surf. And he loved surfing. He was such an avid surfer. And there was something about not being able to surf that just made him feel like there was nothing to, it was the most important thing for him. It was just the thing that let him feel free and let go of his stress, his PTSD, his depression. It was the one place where he felt good. And he felt like without that, there was no way he could engage recovery. And what he ended up doing, and he figured this out on his own, was he actually ended up going to these surf competitions of these teenagers that used to go out surfing and doing these surf competitions. And he used to take photographs and then share it with the team. And that was the way that he could engage. That was totally different than actually being out there and surfing, but really gave him that sense of joy. So sometimes it's about pacing, and sometimes it's about, I think, modifying the task and figuring out how you can still engage, maybe in a way that's a little different.
Which probably opens a bunch of other windows that one never thinks about until one's really faced with making that shift. And I was thinking along the lines of PTSD, and for example, when you're doing in vivo exposures, I think sometimes we don't necessarily think about the impact of that on pain either. So if I'm setting up a hierarchy and somebody's, supposed to, Walmart's always on the list, and somebody's supposed to approach Walmart, not Target.
I mean,
not
it really
Kohl's.
should be in the diagnostic criteria, at least when you're working with people in North America,
Yeah, exactly. We just can give out Walmart gift cards and see what happens. But I think, we're really trying to set up the exposure to be successful and to, have our client be able to go and experience the anxiety and come through it on the other side and kind of have it come down on its own. But that involves physical tension, right? Muscle tension and other kinds of tensions that, in addition to it being unpleasant psychologically and causing significant anxiety, when we've got somebody with chronic pain, it really can have an impact on that as well. And so how do you, how do you work with that in the context of those kinds of situations?
Yeah. So I think part of it is just the assessment process itself, right? So making sure that we're paying attention to this. I think in integrated medical models, pain is a lot of times kind of viewed as a fifth vital sign, right? We look at temperature, rate, pulse, blood pressure, and pain. And one quick and dirty way to ask patients about their pain is just on a scale from 0 to 10. So where 0 is indicating no pain at all, 10 is the worst possible pain imaginable. You could even ask them to provide you with ratings of the average, worst, least pain over the course of the week. But we know that there's obviously some very clear pros and cons to this. So on the one hand, that gives us an idea of where somebody's seeing their pain. On the other hand, it's going to be extremely subjective, right? Somebody's 4 might be equal to somebody else's 7. And so because of that, because of the difficulties, I think, with Likert scales, there's a lot of different types of scales that you could really integrate into your assessment to get a sense of where somebody's pain is, and maybe even make modifications to your exposure exercises. If it's using visual analog scales, if it's using pain rating scales like the DIV-PERS or the West Haven Yale multidimensional pain inventory. There are even scales that look at functioning or even cognition, like the pain catastrophizing scale. So just having some level of familiarity, I think at the outset, as you're really engaging your case conceptualization and really kind of getting a thorough understanding of what's going on with the patient, getting that kind of idiographic map of what is the story here and how do I best help them, that really informs our treatment plan, I think you can start to incorporate that. The other thing that I think is really critical with pain patients is relaxation, right? So relaxation techniques are these fundamental skills for managing chronic pain. So this, notion is not necessarily unfamiliar to people, but I think helping them to understand the rationale behind it, right? That these can be really, really important because we're focusing on pain as a chronic stressor, both physically and physiologically, right? And physically and psychologically. And so you were talking about that, Jenna. You were talking about the tension that people experience when they go out and do the exposure. And so we know that this happens with both diagnoses, right? With PTSD and with chronic pain, there's this tension that occurs. The body is reacting. The fight and flight response is essentially activated, this stress response that's controlled by the sympathetic nervous system, which is important and critical for survival when we're facing dangerous or stressful situations. But what we want to do is teach them that for both of these diagnoses, engaging the opposite physiological response, really activating that parasympathetic nervous system, can play a huge role. So I think assessment and relaxation techniques, especially with folks that have these comorbid pain conditions, can go a long, long way.
Yeah, I agree. I think the other piece that, in my experience of working with patients who had chronic pain, was what their expectation of of me and my reaction was going to be. These are, and again, this is in my humble experience, patients who have gotten a lot of different receptions to their pain, some good, some not so good. And so, Andy, kind of going back to that client you were talking about who didn't, was like bracing and making noises, but had never sort of talked about pain. Some clients really want to talk about that and bring that to the table, but others are really hesitant because they've had negative reactions from providers or feel really frustrated with the medical system and systems they've been in to try to manage their pain. And so, I think getting back to the rating scale, asking the questions important. I think we're a little sometimes I feel numb to that because we get at, it's like now the new question is, have you fallen lately? Or, there's like stability questions that are being asked now, but because it's asked so often, I think sometimes people do blow it off. But if you ask about it in a compassionate, empathic, meaningful way, and then kind of talk about that relationship to what's going on with them clinically, and then in terms of your treatment plan, and even with the example we were talking about with exposure, maybe they're rating their subjective units of distress, but they're also rating their levels of pain, and you can kind of watch those and track them over time. As there's less bracing, and the anxiety is kind of going down, maybe you're going to see that change over time too. So I think all those, I think it'd be good to talk at some point about tools. If there's, we like to have folks walk away with practical things they can employ, and certainly we'll ask you for that actionable intel at the end. But any resources or tools you think that our group of providers would want to access?
Yeah, I think there's a couple of really good resources. I would say if I could give folks one tip, it would be don't be afraid to engage pain, even if you're not formally trained. First of all, the Center for Deployment Psychology does have a 2-day EBP for CBT for chronic pain. So if folks are interested, please come join us. It's a great training. and really talks about how we make modifications to CBT to apply it specifically to chronic pain. But even if you're not trained and you have that patient that's coming in for depression, PTSD, anxiety, whatever it is, and chronic pain is that uninvited guest that's showing in on session 6 or 7 or 8, and you didn't notice it prior, don't be afraid. A lot of the same techniques are overlapping if we're looking at the behavioral techniques, the cognitive techniques, the problem solving techniques, the relaxation techniques. Just don't fear it and start to look at the overlap. There's some really, really, really nice resources, and I'm happy to provide you with the links to them. The VA actually developed a really well written manual with included worksheets in it for CBT for chronic pain. It's available in the public domain for whoever wants to access it. They also have a chronic pain website. So they have a website that talks about chronic pain resources, including not only the manual, but they have a list of different videos that kind of walk you through an example of a VA therapist working with a veteran, really working through different types of skills, talking about psychoeducation, talking about how to engage the primary care doc if you're working with folks with chronic pain, talking about all kinds of different skills and techniques, which I think can be really, really useful. And the Association of Behavioral and Cognitive Therapies also has a webpage specifically for chronic pain, where they have a variety of resources as well, including fact sheets that really go through and provide a nice, thorough understanding of what is chronic pain, what are the causes, and what are some good treatment interventions. So lots of good information that's out there available and accessible.
So we really appreciate you coming on the podcast today. And there's a couple of things that I heard you say throughout our conversation that seemed to, be in the neighborhood of actionable intel that I wanted to run by you and just see if this made sense. So I think I love your first, sort of piece there, which is not to be afraid of it, to ask about it, to engage it. You also mentioned assessment, being really important. And you mentioned a number of different assessment tools in our conversation today. I believe at least several of them are available in our patient forms page. And so hopefully we can include some additional links for other measures that maybe aren't on the page already. And you mentioned relaxation techniques, which I think is part of the repertoire of most CBT therapists, and maybe not something that most CBT therapists think are a good intervention for chronic pain, but that could get you, into the room with somebody and help them pretty quickly and doing some of those techniques. I know it's breathing exercises are part of the PE protocol, for example. And so it's actually built into some of the EBPs. So not being afraid of it, doing some good assessment of it, and maybe incorporating some relaxation techniques seem like a pretty good place to start.
Absolutely, Andy.
I appreciate the summary of those actionable intels. There's some very good ones. The one last little one I wanted to ask about, because again, I know your other area of significant expertise is in suicide prevention. And we know there's a relationship between chronic pain and suicide as well. And, given that we have some good interventions for suicide, any actionable intel kind of in that realm that if there is, advice you would also give if there's concerns regarding that.
Yeah, that's a great question, Jenna. With kind of the link between chronic pain and suicide, I think we have trait unbearability in the literature, and we see over a twofold increase in suicide risk with those individuals that are coming in with these cognitions around trait unbearability. So what I'm talking about is really when you're in the room clinically with a patient, is to start to keep an open ear for statements such as, I can't take this anymore. I can't deal with this anymore. Things will never get better, because those are the exact type of cognitions that lend to hopelessness, which we know is the second strongest correlate for suicide risk. So those are really the things that I'm looking for that are indicators that there might be an increased risk for suicide. And I might even want to engage in a suicide risk assessment at that point in time. But those are certainly areas that I would want to tackle clinically. So those are the exact cognitions that I would prioritize in tackling when I'm working with a patient presenting with pain. Great question.
Great. Well, again, we are incredibly grateful not only to have you on CDP faculty, but that you jumped in and joined us today, and are definitely looking forward to some future conversations, more actually about suicide prevention. So wanted to give you a huge thank you, and hope that everybody walked away with some good insights. And, the main one being, I think, again, this idea of don't be afraid and approach, and we'll definitely try to include some resources. So thanks so much, Sharon. We really appreciate it.
Thanks so much for having me.
Thanks for listening to Practical for Your Practice.
Please feel free to subscribe, rate, and join in on the conversation in the comments.
Until next time.